Bismillahirrahmanirrahim. Hi everyone. In this short video, I'm just gonna talk really briefly about some tips for addressing hyponatremia. As you know, hyponatremia is a very common inpatient problem. It's actually the most common electrolyte disturbance that hospitals see and acute medicine physicians see in their hospitalized patients. Again, this is going to be short. If you want a little bit more details, you can always check my series on hyponatremia. Most of these videos are very short videos, really kind of discussing almost all the aspects that I have faced in hyponatremia, so hopefully you can find it useful. But in this video, I'm just gonna give really some tips that I found useful, and I think many residents and physicians, hospitalists forget about it. So the first tip is not to forget to check the serum osmolality. I believe this is probably the first test that most patients with hyponatremia will need, and I have seen this quite often. That is usually not done or not missed, but it can really save you a lot of time if you do it early on. So for example, just recently I have a patient who had persistent hyponatremia 22. The team did not do serum osmolality. In our system, EPIC, there is usually the calculated osmolality, which is honestly is useless. I don't know why it exists, to be honest, but regardless, it takes the sodium level that's already posted in the lab, and then it calculated the serum osmolality based on that, 2 sodium plus urea plus glucose. But this is not really the actual osmolality. You really need to have a separate order to check the real osmolality to see if this is hypoosmolar hyponatremia, isoosmolar hyponatremia, or hyperosmolar hyponatremia. Again, this can save you a lot of time, so think about it whenever you have a patient, especially if it's persistent, especially if it is resistant to treatment as well. So in this patient, we did that. We checked the serum osmolality, and initially the patient has some hyperglycemia. I think he was some DKA or something. So the osmolality was actually high, and then it was normal, and then it kept staying normal despite the fact that the patient was still hyponatremic. So that was concerning for isoosmolar hyponatremia. And the top differential for that is pseudohyponatremia. So what to do in that case? To confirm the diagnosis, you have 2 options. You can call the lab to change the dilution method that they usually use to check the electrolytes, if your lab uses that method. But even nicer, you can just order electrolytes in the blood gas sample. The ABG sample, instead of running ABG, you can just run the electrolyte, including the sodium. And we did that in this patient, and it came back only mildly low. So it's 130 instead of 120. So we know that this is not really severe hyponatremia anymore. It's only mild hyponatremia. Nevertheless, we also want to know why this phenomenon happened. So the 2 tests that you usually order is the triglyceride or lipid panel, and the other test is total immunoglobulins and SPEP and UPEP, serum protein electrophoresis and serum protein electrophoresis. And the SPEP UPEP came back abnormal, although it's not conclusive. As you know, the kappa lambda ratio, if it's more than 1.5, 1.6, this is indeterminate. If it's more than 5, this is very suggestive. And if it's more than 10, this is very, very highly suggestive, almost diagnostic of multiple myeloma or monoclonal gammopathy. In this case, it was kind of indeterminate, and we think the patient had polyclonal gammopathy from other chronic issues. I think, if I remember correctly, he had some liver disease or something like that. So it wasn't definitive for multiple myeloma, but at least we knew that, his severe hyponatremia is not actually severe, and he had some polyclonal hypergammaglobulinemia. So that was helpful. Again, I have seen it quite often. So check serum osmolality initially in patient with hyponatremia, especially if it's resistant to treatment, especially if it's severe or the cause is not really known. Now, the second tip is to check the serum uric acid. Serum uric acid is your friend. It is indeed. If you remember from what we discussed before in the hyponatremia series, in SID, the patient had access to water and the thirst mechanism is suppressed. This will lead to hypervolemia, increase the volume intracellularly and extracellularly. Somehow that will inhibit the proximal convoluted tubule, and that will lead to loss of electrolytes, sodium chloride, and uric acid as well, or urate. This is kind of a compensatory mechanism to try to bring the volume down. So as you can see here, the uric acid excretion will be high. So that will lead to a decrease in the serum uric acid. Just as a side note, this is one of the reasons why if you give this patient normal saline, actually it's not gonna help. Actually, it can make things worse because it's just gonna feed this mechanism and increase the volume status. So don't do that. So again, checking uric acid is very helpful, I believe. It's not part of the diagnostic criteria, the 5 diagnostic criteria we talked about in SID, but nevertheless, it's very supportive. So if you find, again, a uric acid less than 4, then this is, which is found in 70%, more than 70% of patients, this is really very helpful. And if you even have this test in your hospital, you can do the fractional excretion of uric acid, and if it's more than 10%, that also suggests a supportive diagnosis SID. Again, because of the mechanism that we talked about. It's not part of the diagnostic criteria, but it's very supportive and very helpful. Sometimes it's hard to differentiate between SID and hypovolemia, especially if it's mild, especially by physical exam. And in that case, really, the serum uric acid can be helpful because in situations where, for example, salt wasting, and this can really mimic SID, the volume status is low. So if you do serum uric acid in salt wasting syndromes or hypovolemia, you expect the uric acid to be concentrated and in the higher side, probably more than 6. But in SID, it's usually low and usually less than 4. So remember uric acid. And then third tip is really focus. I think, focus can be very helpful in these patients. As you remember, assessing volume status is also key in patients with hyponatremia. People classify it based on that into hypovolemic hyponatremia, and hypervolemic hyponatremia. So, you can see something like this, suggestive of hypovolemic hyponatremia. IVC is really small. You can see something like this, where the IVC is really large, here like almost close to 3 centimeters, and doesn't collapse with inspiration. Or, these situations would be very useful, but sometimes it's not, to be honest. The IVC can be like in between, so it could be either way. So again, IVC specifically is not like 100% diagnostic, but it's very useful. I really found it very useful in assessing the volume status because it's more sensitive than physical examination. And I talked about that in one of the reviews that I had about the volume status and the tools that physicians can use at the bedside. And then also with hypervolemic hyponatremia, like for example in CHF can really be picked up nicely with POCUS, even better than chest x-ray, definitely better than physical exam. So that's why it's really very helpful to have POCUS, point of care ultrasound, as one useful tool to assess the volume status in patients with hyponatremia. And then the last tip I want to mention is really the discussion that's happening about the rate of correction of hyponatremia. As you know, the guidelines so far, they recommended that you avoid overcorrecting hyponatremia because of the changes that can happen at the cellular level and developing of the neuronal shrinkage and ODS, smaller demyelination syndrome. And there is a recent study, a systematic review, nicely done, I believe, that actually looked into evaluating the association between an overly rapid rate of sodium correction, and rapid meaning not like slow at 6 or 8, a little bit more than that, technically 8 to 10. This is considered by the study as a rapid correction compared to patient with slower correction, where they did about 6 millimeter of mercury of the sodium, and they compared the risk of ODS. This is kind of the primary objective, but they also looked at other issues like, in hospital mortality, 30-day mortality, and hospital length of stay and ICU length of stay. And they found like around 11 cohort studies and a total of 26,710 hyponatremia patients. So what they found is, this is for the primary outcome or the incidence of ADS. The good news is the incidence was absolute incidence was very, very low. Less than 0.23% overall in all these, about 23,000 or more than 23,000 cases. Nevertheless, the rapid correction was associated with increased risk of the ODS patients with an odd ratio of about 3. But again, the good news is that the rapid correction, a goal of 8 to 10 milliequivalent per 24 hours, the rate for ODS for this patient is really, really low. And the other good news is that the rapid correction was associated with substantially lower hospital mortality and also lower 30-day mortality and also shorter hospital lengths of stay, but about 1 to 3 days, and also shorter ICU lengths of stay, about 1 to 2 days. So that I think was very useful. That doesn't mean like you should. It's okay to like overcorrect every single patient with hyponatremia, because like if you remember from the discussion before about this, hyponatremia is actually there's certain patient that has higher risk to develop ODS compared to others, and this is a patient with severe hyponatremia, elderly, female, associated hypokalemia, especially if it's severe, malnutrition, alcohol use, or liver disease. So this patient maybe be careful with overcorrection, but generally, especially with the incidence of ODS being very, very low, I think it might be not a good idea to keep your patient with hypo longer than necessarily, and that could be associated as with worse outcome especially in the short term, as we saw in this study. So just something to think about. I mean, if more information, more data come supporting this, I believe the guidelines might change down the road. So just to recap really quick, in hyponatremia, the 4 tests that I almost order in every single patient is serum osmolality, urine sodium, and serum uric acid. This is very helpful. And then use of physical examination and better use of BOCUS to assess the volume status is very helpful. And then pick your correction rate, based on the type of patients and the clinical scenario. So again, you can always go back to the hyponatremia series if you want to have more details about hyponatremia. Hopefully you can find it useful. Please let me know if you have any questions in my channel, and I will be more than happy to discuss this. Thank you very much, and really wish you happy 2026. Bye bye.